Hi, it's Dr. Oscar Serelak. Today we're going to do a Facebook Live on uh, thyroid, and it's a very big topic when you're looking at something like thyroid function. So what I really want to focus on mainly is maybe looking at thyroid health and function during pregnancy and in the postnatal period as well. It's such a crucial hormone. One of the interesting things that for me, just in my career, when I was a medical student, thyroid conditions were quite rare. And typically we saw that, as a medical student, I would see that in elderly females. And then as a sort of a junior doctor and within the hospital system, I was, you could definitely see that the age group was much younger of females having sort of thyroid issues. And now later on in my career, I'm seeing thyroid issues in females that are much younger, teenagers, and young women in their 20s. And it is becoming a big issue around fertility as well as general sort of well-being. And the rates of a lot of autoimmune thyroid issues are definitely going up. And so, it's a pretty big topic. I think it's quite misunderstood what the thyroid actually does, and so and it's quite a unique hormone in terms of what it does for how it behaves in pregnancy, um, and um, so yeah, so we'll talk. Yeah, so I just want to sort of break it down, and we'll talk a little bit about sort of thyroid anatomy, thyroid physiology, and then kind of how that relates to pregnancy and postpartum. It's one of the things I've always found fascinating about thyroid is that typically these thyroid issues affect women about 5 times more than they do men. Uh, it's interesting that there isn't clear idea from the medical world why that is. I certainly have my ideas around that, but it's not like it's well known um, why it happens so much more in females than in men. And in a nutshell, I think it's because females have fluctuating hormonal levels and they're more sensitive to toxins from our environment. And uh, and these toxins tend to really affect the thyroid principally. I mean, a really good example around that is things like radioactive fallout. So for Fukushima or something like that, um, uh, the rate of the thyroid picking up radiation and later then developing thyroid cancer uh, really goes up just with that toxin exposure and not so much other hormonal sort of systems, just as an example. So let's talk a little bit about the anatomy of thyroids. So what I'm going to do here, so the word thyroid itself comes from Latin, then from Greek, then into Latin, meaning shield, because the thyroid looks like a shield. Some people say it looks like a butterfly, and if you can sort of see that there, and it sits basically over the Adam's apple, and so the name means sort of shield. I've got the thyroid that works here, and the thyroid takes signals from the brain about what to do, and then it produces, or within the thyroid, it makes thyroid hormone, and it's mainly in the form of something called T4. So T4 basically means tyrosine with 4 iodines coming off it. So tyrosine is a base amino acid, and we've got the 4 iodines that are coming off here. Okay, so we've got the image not quite the right way here. So let me see if I can get that a bit better. Okay, it's the first time I'm sort of trying this, so bear with me. Always some technical. Uh, so yeah, is that better? Yeah. So let's see how we sort of go here. Sorry about the shadow of the cord. And so the T4 um, is inactive, and that's what the thyroid mainly produces within the body in various different places. It gets converted into T3. T3 is active, and as you would imagine, um, uh, what happens is one of these iodines gets cleaved off here. And so this is where you get T3. And then the body also produces a small amount of reverse T3, where the iodine is cleaved off on the other side. So it's a mirror image. Yeah. The reason why the body does that is because if the body needs to go into hibernation or wants to really become very resilient in using its resources, and we're in a period of food shortages, it will actually produce more reverse T3 than T3, and then the body becomes quite um, uh, efficient, if you like. And so there's nothing wrong with reverse T3 necessarily, but if there's too much reverse T3, this is the T3 then. And what happens to the T3? The T3 actually goes inside the cell, docks into what's called the nucleus in here, and basically stimulates the receptor here, and it tells the cell how much energy it's allowed to spend. So one of the principal things around what the thyroid does is I imagine it's like the treasurer or the CFO. It's only really got one job to do, and that's to actually go in here and dock into the receptor and give the cell a budget, if you like. Reverse T3 when it docks into here, um, uh, blocks the receptor but doesn't give the cell a signal. So it's kind of like a false signal, but this is how it can reduce energy expenditure and the sort of budget, if you like. So um, it's quite important to understand this, and thyroid is unique in the sense that um, it's the only hormone that really has one job to do. Whereas when you look at cortisol, when you look at other hormones, they have lots of jobs to do. Thyroid only has one job to do. Thyroid works very closely with cortisol to then enable that energy production. This is why people with underfunctioning thyroids tend to feel the cold more. And a really useful thing, I think, for anyone who's concerned about is their thyroid working well or not, is to do something called a basal body temperature. So the end result of the thyroid sort of docking in and telling the cell its budget is energy expenditure, and then energy expenditure turns into heat, if you like. And so a basal body temperature is when you first wake up, ideally before you get out of bed, and you write down what your sort of temperature is. And so in Celsius, ideally you want that early morning temperature about 36.5. Anything below 36.0 ongoing really points to the possibility of an underfunctioning thyroid. Because of the dip around ovulation, where temperature fluctuates, you need to do it over at least 10 days to average it out. But I think that's a really useful thing that we're doing in my clinic all the time to see about the manifestation of what the thyroid is doing. So and again, in that sort of process, there are a few things that are obviously really important for the thyroid to work properly. One is having enough tyrosine. Tyrosine isn't often a problem. People can be deficient in this amino acid. Iodine is definitely a very common deficiency, especially in Australia. Um, for decades, we had accidental contamination of our food through something called iodophores. So they would clean out the milking vats with iodine, and that would leach into the milk. And so very few people, especially drinking milk or milk products, would have an iodine deficiency. In the 1980s, they changed cleaning these vats with bromophores, not iodophores. And so suddenly we started seeing a lot of iodine deficiency in Australia. And this and if your soil doesn't have iodine in Australia, a lot of the iodine is just washed out into the ocean. You need to be getting it from ocean sources or from adding it to your compost, as it were. And so iodine deficiency is very common. During pregnancy, there is quite a variation in how much is recommended. I've always found this very interesting. Some supplements have about 125 micrograms of iodine, some have 150, some have 175. The World Health Organization recommends 250 micrograms per day um, for a conception, pregnancy, and in the postpartum period. But the recommendation is not to have more than 500 micrograms per day because that can actually cause uh, the thyroid to work less well. And so I think what each country might be doing is trying to guess how much someone might be getting from food and then just supplementing with a variable amount. But I think it's really important to get enough iodine supplementation because it can be quite hard to get it from diet. Um, Iron is also very important for putting those iodines on the tyrosine molecule, as is selenium. So they're really key minerals in this whole thyroid health picture. And then I think just the whole role of stress. So again, if you're the more stress you have, the more reverse T3 you might have, or the more stress you have, the more cortisol you might be producing, which is blunting the effect of the thyroid on, or the thyroid hormone on the cell receptor. And so it's a quite a complex system that the body sort of has. But we're going to talk a little bit about what happens during pregnancy and postpartum with thyroid because it's quite a shifting landscape, if you like. Thyroid disorder during pregnancy is the second most common hormonal issue during pregnancy. The first is diabetes, so that's to do with sort of insulin. And about 2 to 3% of mothers will have quite severe hypothyroidism during pregnancy who have never had thyroid issues before. The baby, so the fetus only starts to actually really grow its thyroid around 10 to 12 weeks, where it starts to actually start working, but it's not fully mature till well into the third trimester. So unlike all the other hormones that the placenta makes for the baby and for the mother, thyroid is the only hormone that the placenta doesn't make, and the baby, up until often the mid third trimester, is totally dependent on the mother making thyroid hormone. Now, the mother has to increase her production of thyroid hormone by 50% leading into the third trimester. So how does the mother do that? And so part of what can happen is if you've got what's called subclinical thyroid issues, so it's not actually manifesting as a disease, but it's ticking over in the background, you may really struggle to make that extra 50%. And it's a real bugbear of mine that it's not a much more important part of not only the screening early in pregnancy, but also when we're looking at 28 weeks or 36 weeks, just to really understand what is happening with that mother's thyroid production, knowing that it's really important for her and for the growing fetus. So one of the things that uh, the body does is with production of HCG. So we all know this as the hormone of pregnancy. That's how they measure pregnancy, through urinary dipsticks or through blood tests. The HCG actually stimulates the thyroid to do. The average mother's thyroid grows 10% during the pregnancy, and it's quite common for this HCG effect to drive thyroid production too much initially, and you can often see the TSH, which is measuring, which is a key marker of how the thyroid is working. So TSH is thyroid stimulating hormone, so the brain talking to the thyroid. The lower it is, the more overactive the thyroid is, and the higher the TSH is, the more underactive it is. And so what we actually see is a shifting of the goalposts during pregnancy, and 15% of mothers who have no thyroid problems, who won't have a thyroid problem, their TSH actually gets pushed below 0.4, and so it gets pushed into the zone of what would be considered hyperthyroid. And so a lot of countries, the USA included, shift the TSH goalposts, if you like, for pregnancy. There is a real movement in Australia to sort of start doing that. And the other thing that the body does is it increases something called thyroid binding globulin significantly. The thyroid binding globulin actually binds T4, T3, and it really makes sure that the T4, T3 aren't cleared away too quickly. So it's kind of storing them and then making sure that the body's not clearing them too quickly. So we talked about sort of the shifting goalposts, and there is a movement within thyroid associations to really make that higher, what is considered hypothyroid. In Australia, labs may have 4 or 5 as their TSH before they'll say someone's hypothyroid, so underfunctioning. Most international bodies are now saying 3.5, including most European countries. And there's a real push that during pregnancy, we maybe should be looking at 2.5 as kind of the ideal sort of, to get it between 0.4 and 2.5 is the ideal for that. And an example of why this might be so important. Thyroid antibodies that are typically seen with Hashimoto's. 5 to 20% of women of childbearing age have thyroid antibodies within their when they're sort of doing blood tests. So it's a lot. They know that thyroid antibodies, if they're there, associated with a lot of things, including pregnancy loss. So when you have a look in fertility clinics, if any mother or woman trying to get pregnant has thyroid antibodies, they'll often give the mother a low dose of T4, 25 to 50 micrograms typically, and really try to push that TSH below 2.5 because it really helps with pregnancy outcomes, just because those thyroid antibodies are associated with spontaneous pregnancy loss. Something else that's also very interesting is that 50% of mothers who have thyroid antibodies before pregnancy will actually go on to then develop postpartum thyroiditis. I'll explain a little bit more what this is. And so it's a huge risk factor. And so again, there's a huge push to have that as a screening test to then predict who is going to get postpartum thyroiditis, because the rate of postpartum thyroiditis is 7 to 10%. And typically, what happens is that there is it's interesting, its other name is non-painful thyroiditis. So there is a stimulation of the thyroid gland, um, and uh, enlarge, and two things can happen. It can either be pushed into becoming hyperthyroid, so that stimulation can actually produce too much um, thyroid hormone postnatally, or it can actually push into hypothyroid. Sometimes it can actually do both within the same mother, not at the same time, but just over the time period. And a really groundbreaking piece of research was called the Danish um, postpartum thyroiditis study that followed several hundred thousand women in Denmark over many, many years. And they saw that the peak incidence of the thyroiditis was nearly a year after um, uh, the birth of a child. So, again, this whole idea of um, 6 weeks for physical issues, 6 months for psychological issues. Here you have a condition known to be related to postpartum, actually peaking at a year post the birth of the child. So just recently, international bodies have now moved the goalpost for postpartum thyroiditis to be 12 months after the birth of the child. So um, most so we've got a question here. So Susie, thanks for covering this. Do you ever see women who are showing the opposite symptoms of their condition, e.g. they have hypothyroid but show hyper symptoms and vice versa? Um, what I think might be going on, yes, you can, but if you've got hypothyroid, you've got hypothyroid. You're not going to be tipped. But what can happen with hypothyroid is that the body can experience an energy crisis, and if cortisol is not able to really take up some of the slack, um, that underfunctioning cortisol, or if the cortisol goes way too high, can actually mimic some of those hyperthyroid symptoms. So I think it's uh, so Susie, you're quite right that that can happen, and again, thyroid symptoms are not clear cut. Every person with hypo or hyperthyroid gets the same sort of symptoms, and again, it's happening within um, a group effect. And if we come back to our analogy of the board meeting, just because the CFO or treasurer, the thyroid isn't doing their job optimally, it depends on what those other board members are doing in response to that. I think that can really bring out some of these other symptoms. Um, so, so we talked about, and again, most people don't, or most mothers don't need treatment for postpartum thyroiditis, but it's really quite important to monitor. Often you do need to ultrasound as well to see what's exactly sort of going on, just so you've got your diagnosis right. And you often need to do blood tests to monitor what is going on with it. And I'm often amazed at how under, not necessarily undertreated, but under monitored things like this can be. And I've heard of lots of mothers who said, "My goodness, my thyroid swelled." No one kind of really sort of took any notice, and they may have had 6 or 12 months of having these thyroid sort of symptoms. What's interesting is that postpartum thyroiditis and the thyroid swelling was first noted, I think, maybe 2,500 years ago in ancient Greece. Solarius, I think his name was, and was known that mothers could have this issue, and they also knew that there was something in seaweed and sea food that really helped with this. in ancient China, people in the mountains, I think this was documented maybe 300 AD, um, they would have to, they were told that they would have to take respite down by the sea and eat seaweed and other things. So they didn't know why necessarily, but that was always the treatment for that. Um, so just to talk to your question a little bit more, Susie, we'll talk about what some of the symptoms are. So with hypothyroid, typically we get fatigue, we get cold intolerance. So again, if your basal body temperature is going down, you're going to feel the cold more, and it's going to be harder to increase your core temperature to match what's going on the outside. Weight gain can be quite common. Constipation, thickening of the skin. Interestingly, you can lose the hair on the outer third of your eyebrow, especially if it's been going on for some time. And your reflexes slow down. So the doctor will often test your reflexes to see if your reflexes are really quite sluggish. That again is really pointing at a thyroid hypothyroidism. Whereas with hyperthyroid, you can often get symptoms of heart racing, sweating. You can get what's called the thyroid stare, which is where your eyeball can actually move forward quite a few millimeters, and you can see the white part of the eye surrounding the iris. And so it really looks like people are staring at you with this, and it's called exophthalmos, and it's a classic sort of finding with hyperthyroid. And then you often can get goiter. Goiter is just a swelling of where the thyroid lives around the neck. And I'm always looking at my mother's, what's going on around there, and have they noticed it? Can I see something? And then when you're feeling around here, does it feel quite puffy? Now, why is this important? Untreated hypo or hyperthyroidism can have quite significant problems both for the mother and for the fetus, and everything from things like hypertension, small foot dates, babies, obviously things like cretinism on the severe end of the spectrum. But many of the poor maternal and fetal outcomes have thyroid as a potential player within that. So this is why I'm always talking about why it's such an important thing. So we've got a few more questions that I might just sort of cover now. So we'll work out a few here. So Monica's asking around postpartum hormone imbalances. Is there any other factors that can lead to underactive thyroid, e.g. stress or high cortisol before pregnancy or gestational diabetes? I'm 12 months postpartum and I'm still on levothyroxine and still waiting to see when things will normalize. So I'm always thinking around autoimmune issues because they're the most common. Thyroiditis, also very important to sort of look at postpartum. And then looking at deficiencies in iodine, iron, selenium, certainly very important. Looking at sleep and healthy cortisol, I think is really important as well. So really getting that relaxation response in, and sometimes there can be a whole range of thyroid herbs that can make a big difference as well. Now, I'm not a herbalist, so I'm always referring to my naturopaths and herbalists for this, but magnolia, romania are just some of the ones that are typically sort of used, but there are many. Gestational diabetes can certainly be sort of implicated in that as well. And the thyroid just happens to be very sensitive. So I think it's because on the surface it might be sensitive to things like radiation, as we mentioned, but I think it can be very sensitive to emotions. A lot of sort of psychologists and transformational workers often talk around the thyroid as where the voice box is, and the thyroid represents often having our voice. And so having thyroid problems can represent compromise. And so, uh, certainly a lot of the transformation workers that I may sort of work with or that I see really look at where are you compromised, why aren't you able to really speak your voice, uh, and especially around thyroid. Kristen's asking here, what do you think is driving the increase in postpartum thyroiditis incidence? Is it controlled inflammatory state of pregnancy, immune suppression, uh, iodine, tyrosine, iodine deficiencies, or all of the above? It's all of the above. Yes, we're having babies older, so I think that's also part of it. There are so many thyroid toxins out there, and we'll talk a little bit about goitrogens at some stage, but the thyroid toxins are anything that interferes with iodine. So chlorine and bromine can very much affect thyroid function. And the goitrogens are typically foods that may block the uptake of tyrosine or how tyrosine works within the thyroid. Again, it's not super well studied just because it will take a very large bucket of money to look at this in the detail that the medical world would need. But some of the goitrogens that have been suspected and looked at include soy. It's probably the most common. Some of the other common goitrogens include brassica family of vegetables. So these are things like broccoli and Brussels sprouts. They can definitely be implicated. And then you have a few odd foods like pears and I think peaches. I'll have a look at my list here because it's one of those things that's not that easy to remember just because they seem not to fit into a food group. So pears, peaches, peanuts. So I should maybe remember the three P's there. Millet and spinach. And so again, it's not about avoiding these foods, but maybe reducing them until your thyroid comes back online at least. And thyroid, I'm totally fascinated with thyroid because it doesn't behave like any of the other hormones. Certainly early on, I would do everything that I could do to get someone's thyroid working better and get them off medication. And sometimes the thyroid just won't. Often the thyroid just won't come back online, and so that's become a lot less of a goal with my work. And more about just making sure that the body is happy from a thyroid point of view. So Emma's asking here, do you believe dairy needs to be avoided with Hashimoto's? Do you recommend a food sensitivity test? So I've certainly heard a lot about, and this is really through work, researchers like Sarah Ballantyne and the autoimmune paleo, where they really get everyone off gluten, grains, and dairy because they believe that that has quite a big impact on all autoimmune diseases, including Hashimoto's and Graves' disease. And the research is pretty thin on the ground. But I'm always curious about because the research shows that every autoimmune disease essentially has a gut origin. And what I mean by that is there needs to be enough autoantigens presented to the body to get the immune system to overreact and cause an autoimmune disease. So the researchers have shown that the gut is the main source of these autoantigens, and there's often leaky gut or increased permeability during a period that will then give enough foreign molecules for the body to start reacting to. And so it doesn't necessarily mean you've got any gut issues by the time you're diagnosed with an autoimmune condition, but you certainly would have at some stage had a thyroid crisis, a gut crisis, or a gut issue that was part of the genesis. Leaky placenta may also be part of the genesis of Hashimoto's. And I've certainly come across some research implicating male babies being more stressful to a mother's immune system than a female baby in utero. And this is probably because of presentation of that male DNA via the placenta. It's a fascinating topic and very under-researched. So let's answer a few more questions here. Do you recommend seeing an endocrinologist on, say, a yearly visit as well as your GP when taking thyroxine? If your GP really knows what they're doing, you don't need to see an endocrinologist. Endocrinologists, I think, can be quite useful in that initial period when we're trying to get a diagnosis or a clear understanding of exactly what's going on. Once you're stable, your GP should be able to manage that. Melanie's saying I've been diagnosed with chronic fatigue and Hashimoto's. She's on T3, 10 micrograms, and has a high reverse T3. Any idea what causes the high reverse T3? So I'll just say you're a little bit unlucky, Melanie, to have both Hashimoto's and a high reverse T3, but I don't see that often. Again, my belief, and again, there's not a huge amount of research to really be clear on this, but reverse T3, as I mentioned in my diagram, is part of the body is always reversing, always producing a small amount of reverse T3. And if the body is thinking there is a major crisis occurring, so like a famine, a drought, some sort of threat like that, it will produce more reverse T3. And so when I'm talking to all my clients around high reverse T3 and what we're going to do about that, I'm always looking at compromise and safety. Is there anything in the mother's world that may be really compromising her or causing her to feel very unsafe? And what else from a toxicity point of view and from a nutrient deficiency point of view, sleep deprivation, and other hormone point of view might also be telling the brain and the thyroid that there is some threat out there that the body is. What the body does, it just presumes that threat is going to be over in a short period. Reverse T3 goes high, your body goes into this hibernative state or energy efficient state and just waits for the crisis to be over. And of course, if that signal coming into your system about the threat doesn't change, the body doesn't go out of that reverse T3 software. So I'm always looking at the whole spectrum of what's going on in mother's life to understand what's going on from a reverse T3 point of view. Reverse T3 can change wildly day to day, week to week. So it's not something that gets stuck at a certain level and is very hard to shift. So Kristen's asking, is it common to swing from subclinical hypo to hyper and back again after pregnancy? If so, how long after birth does it take to recalibrate on its own? So yes, and I do see this quite frequently. Again, the thyroiditis is part of that. Immune rebound is also part of them. And I would usually test every 2 to 3 months, depending on what's going on. Even when you do something like give thyroid extract, give thyroid hormone, it takes about 4 weeks for the levels to kind of calibrate. And so I would never start a medication, a herb, an iodine supplement, and test before 4 weeks. You have to wait at least 4 weeks to retest, and then be testing. 3 months. 3 months, I think, is a reasonable time to, especially when things are close to being normal. as a marker on the road, are we improving or not? Uh, and typically it will take more than 12 months. Um, so, uh, and if you're still having issues after 18 months after the birth of your child from a thyroid point of view, then there's a much higher chance that it's not going to recalibrate on its own. So Susie is asking, is there research supporting AIP? Yes, there is research, but for it to be medical grade, you often need tens of millions of dollars to do sizable studies. So there are certainly small case studies and lots of anecdotal evidence around that. And then there is biochemical research that shows about how the AIP can sort of help. And then the other part of that question, bloods show you can decrease thyroxine. Is it because your thyroid is regenerating itself? Yeah, so what can happen is that with thyroiditis, for example, you can get stimulation of the thyroid. With Hashimoto's, you can get stimulation. You can also get destruction of the thyroid. And so the average, so if someone had their thyroid removed because of surgery and they were around 40 years of age and around 55 kilos, I think it is, you'd need about 200 micrograms of thyroxine to replace that. And so that's kind of a bit of a ballpark of, so a lot of mothers might be on 50, 75, 100 micrograms. And so you can see that's a percentage of total thyroid production, and the thyroid is actually doing the rest. And I think when you're doing blood tests and someone's on a thyroid medication and they're improving or they're becoming, looks like they're becoming over medicated, it is because the thyroid is either waking up or starting to produce more. And we can definitely see that you get this compensation, I think is the term, and you can actually get parts of the thyroid that grow slightly more to compensate. Olivia's asking here, I was diagnosed with thyroid nodules, had tests done with a biopsy, and the nodules were benign, and the GP basically said there was nothing more they could do, come back once a year or so for testing. So I think 20% of mothers going into pregnancy will have thyroid nodules, so they're quite common. So if a thyroid is considered to be benign, so benign is less than 20 millimeters, I think, from memory. I'd have to, not 100% certain. But if it's above 20 millimeters, you definitely need to get that looked at quite regularly. If they're below 10 millimeters, I think you don't really need follow-up even yearly, but often GPs will do a yearly thyroid scan. And when they're innocent, they're usually what are called colloidal. So colloidal means that they just have colloid in the middle of the nodule. And the colloid can often be made because there is a missing ingredient. And so when you get these multinodular goiters, so these enlarging of the thyroid because of nodules, it's usually because there's an ingredient that's not right. And so that's out of balance with the rest. And so I'm always looking at tyrosine. You can definitely measure tyrosine relatively easily. Iodine as well. Selenium and iron. So they're kind of my key ones. Other ones that I would be also looking at include vitamin E, possibly vitamin A. A lot of research showing that hypothyroid during pregnancy, low vitamin A levels are often really associated with this. Vitamin B2 and vitamin B3 can also be implicated as well. So it might be worthwhile doing testing for this, and it might also be, so to answer your question, Olivia, I probably would be looking at all of those. And the other one that might be interesting, again, not research particularly from this point of view, but just because of the association of low glutathione with thyroid issues, to maybe do a test looking at your glutathione capabilities to produce glutathione, or um, uh, your body's need for glutathione, because that could be part of the healing that you might need to lessen or get rid of these nodules. Typically, doctors say you can't get rid of nodules. Um, I think it's quite a hard thing to do. I certainly wouldn't be saying, yes, I think we can get rid of nodules, but I've seen them disappear. So um, I also wouldn't want to get in the way of anything that would help reduce nodules. Um, yeah, Olivia's saying that the diagnosis came after her second daughter and 5 years into breastfeeding two children. And so I presume there's something around the requirements of breastfeeding, pregnancy. So I would be looking at all those sort of supplements that we sort of talked about, including the vitamin A, vitamin E, glutathione might be quite interesting, even though they're quite down the list of things typically. Um, Lisa Marie's saying here, she's 19 weeks pregnant. She's on the AIP diet due to severe eczema, breakout early in pregnancy. My early pregnancy bloods came back flagged at TSH 0.25. And then after 5 weeks on AIP, TSH back to 1.8. So again, that could be part of that HCG stimulation, but also just having less inflammation with the AIP diet. So I think that's uh, great that you're doing that, Lisa. And I think also it just shows that there are shifting sands around pregnancy with this. Um, yes, Alistair, I will be saving and sharing this talk. Jess is saying, I seem to have all the symptoms of underactive thyroid, but results often come back with the normal ranges on thyroid panel. I'm 4 months postpartum and would like to look at this again. What reference ranges should I be looking at? Um, so again, so during, so ideally the laneway for me is a TSH between 1 and 2. Um, and that's ideal. You don't want it too much below 0.5 and you don't want it too much above 3. Um, I would do your basal body temperatures, as we said, over at least 10 days, and ideally doing that temperature before you get out of bed. Cheap little thermometer that goes beep will be perfect. You don't need anything too fancy. Under the tongue or under the armpit, and then just seeing what your average is over that 10 days. Doing a reverse T3 might also be useful. Looking at the ratio between reverse T3 and T3 or T3 and T4 might also be useful. And then looking at other hormones, because of the overlap, there may be cortisol issues, DHEA, testosterone, progesterone, estrogen issues as well that may mimic some of those hypothyroid symptoms. Bria's asking about numb, tingling face. Not typically associated with thyroid unless you're having autoimmune thyroid issues, and just because you can get more than one autoimmune issue during pregnancy, that may be part of it. Autoimmune manifestation, um, and you can sometimes see that with some of the B group vitamin deficiencies as well. But I would certainly be, if you're having that every day, Brie, I would definitely be seeing a doctor or health professional just regarding other potential causes for that. But I wouldn't be happy just to say that's a thyroid issue. So that was a bit of a whirlwind discussion around the thyroid, mainly kind of focusing on the pregnancy and postpartum period. We also did have a question from Elizabeth around optimizing thyroid in around the perimenopause, and The things I would mainly say around that is yes, we need to have a look at all those things we mentioned about thyroid in terms of iodine, selenium, iron, tyrosine, vitamin A, vitamin E, and vitamin B2 and vitamin B3, but also looking at inflammation, because if you can manage your inflammation during that perimenopause, it's going to help on so many different levels, adrenally, um, from an estrogen progesterone point of view, and from a thyroid point of view as well. So I think the big thing for me is really trying to manage inflammation in its myriad sort of forms. So that's sleep, uh, improving sleep, food related inflammation, toxicity related um, issues, and then really managing any other things that you've got. If you've got gut symptoms, if you've got allergies, skin problems, it's really important to be on top of those, because they're just signs that your inflammation's not being fully managed. Kristen's asking, is the AIP diet a life sentence once thyroid is under control? No, it isn't. I have a lot of people who go off the AIP diet, who do a modified AIP, or who slowly introduce um, suspect foods and see how they react. I think the important thing is not to jump back to just a standard diet straight away. Just slowly introduce things. Um, the big thing for me potentially around Hashimoto's is gluten. Um, and gluten may never be your friend, and that's just a sad reality of things. And that can be because of gluten sensitivity issues, not a gluten allergy sort of issue. But I think it can always just be useful to be just you can always introduce something like gluten or dairy and just sort of see how you go with it. I wouldn't just introduce too many of those suspect foods at once. Kristen's asking what's a good way to test for selenium. Great question. So a blood test is barely useful. You certainly pick up someone with quite significant, someone who's very deficient in selenium. You'll pick it up on a blood test. I would prefer to do a hair mineral analysis. There aren't that many companies who do really good tests, but you can definitely see that, and you can then have a look at selenium, how it relates to other minerals as well, and someone who's kind of slightly low across the board versus someone who's just got specific nutrient deficiencies. And a hair mineral analysis, when it's done well, actually represents what's going on in the tissues, not what's floating around in the blood. So we can miss a lot of things with blood tests, because blood is a relatively dead space, surprisingly. It's a transport medium. It's it just carts things around from A to B, including oxygen. The red cells in the blood are quite robotic. They don't have a nucleus. They die after 120 days, so they're not really living. They're quite robotic. You've got your white cells in there. They're the main living component within the blood. And then you just have lots of stuff pumped into the bloodstream to go from A to B. So, and a lot of levels of many things can change day to day, week to week, and so you really have to know when is the ideal time to do blood tests to look for nutrient deficiencies, and also that which deficiencies aren't great to look at from a blood test point of view. So thanks for tuning in today, everyone. If there aren't any more questions, Kristen's asking around heavy metals. Heavy metals can definitely be related to thyroid dysfunction just because of their effect on halogens, including iodine, and, uh, and that's probably true for lead, for arsenic, for cadmium, and for mercury. Again, it's not easy testing for these things, and it's certainly not easy removing these things out of your system, but especially when I'm getting stuck with, or we're hitting a bit of a ceiling in terms of improving on minerals or certain hormone issues, including thyroid, we may look at heavy metals. So it's a big topic, Um, I'm fascinated with thyroid. Issues around thyroid have been known for many thousands of years. The role of iodine, selenium, very important, and we have to really understand what the thyroid does to understand why it's so important. And again, I always just keep coming back. It's only got one job to do, and that's to set the budget for every cell. So a very important job, and this is why thyroid issues long term can be implicated in every uh, every disorder you can imagine, from cancer to heart disease, those kind of things. And I think part of it is that thyroid doesn't directly cause any of those issues. I think just having thyroid issues that aren't treated um, really contributes to the body being in a financial crisis, if you like, and then it's going to lead to um, uh, any of these major disorders that especially hypothyroidism is associated with. And it's increasing more and more. It's to do with our modern lifestyle. It's to do with the fact that we don't have a lot of downtime. We're constantly on the go, and we're just having more and more unstudied toxins in our environment, and they're having a visible but unknown impact for many, many people. So thanks for tuning in, everyone. Again, if there are any questions, please ask them on through Facebook. I'm always happy to answer them, and these are important discussions. So thank you, and talk to you next time.